Good afternoon. Thank you for allowing me to speak. Can't stand to hear myself echo. I'm Tomas Walker with Dexcom, and as a full disclosure, I am an employee of Dexcom. We chose to take a look at the association between A1C and continuous glucose monitoring derived parameters. Because while we know that A1C correlates well with average glucose, A1C is often misleading as to with regards to the patient's true glycemic control. So we took a look at the relationship between the A1C and the different parameters. So to do this study, we actually took 4 randomized clinical trials that were all completed in the last 24 months using modern, still available continuous glucose monitoring technology using the Dexcom G5 or the Dexcom G4 running the same algorithm as the Dexcom G5. This data came from the Diamond study, phase 1 and phase 2, the Replace BG study, and the Hypo-V study, which Dr. Hermans was mentioning earlier. Each study had at least 24 weeks of intervention where the patients were using continuous glucose monitoring. And at the end of study A1C value was paired to the last 3 months of their mean glucose, and the CGM metrics were derived from the last 2 weeks. This resulted in more than 2 million sets of pairs at the initiation of the study and at the completion of the study, so well over 4 million data points total. And then we correlated that to the following metrics. And we found that higher A1C bins were associated with higher mean serum glucoses and lower time in range. Patients or subjects who had A1Cs of less than 7, the median time in range was actually 72%. So higher than I think we would traditionally expected patients to be. And 90% of the subjects with an A1C of less than 7, the time in range of greater than 57%. Median time serum glucose less than 54 was less than 30 minutes per day for all A1C bins. And I would remind you that the patients had access to the real-time continuous glucose monitoring data during the follow-up phase at the end of the study, so they were actually able to act on the CGM data. But it did demonstrate that we see a positive correlation between A1C and mean serum glucose, a negative correlation between time and range and specific value, and the percentage of glucose values of greater than 250 indicated what I think one of the most important things we found from this paper, or from this analysis, and actually the manuscript is completed in a rough draft, I just don't quite have a ready submission yet, was that if you spend more than 2% of your day with a glucose of over 250 milligrams per deciliter, it's very unlikely you will be able to maintain A1C of less than 7%. Additionally, we found that 90% of the subjects with mean serum glucose of less than 140 that applied to and time in range of more than 80%. So the final takeaway comment I think was that exposure to hypoglycemia was an extremely poor predictor of glycemic control. And the use of real-time CGM value has really changed our real-time CGM has really changed our ability to interpret glucose metrics for patients and have a much better understanding of the control. Where we've always been taught to base everything on the A1C as the gold standard, those of us in practice have come to realize that this is not the method we had hoped to